Hi everybody.
Hi.
Thank you for joining us. Welcome to National Nephrotic Syndrome Event 2020. Unfortunately, we're not hosting it anywhere. Well, I mean, last year it was in Nottingham, but we're here, 38 Southway Drive, Yeovil, Somerset. And Maryam's helping on the technical side, which is fantastic. So we've got a wonderful panel of health professionals. Many of the health professionals I know in person, and so it's lovely to have you all here. And lots of people said they very much like many of you to join today, because they've got many burning questions to ask you all. And so first of all, I want to introduce myself to those who don't know me, because I know there's probably a few people on here whose children are newly diagnosed as well. So I'm Wendy Cook. I'm Director of Nephrotic Syndrome Trust, or you may know it as NEST. The charity's been running for about 15 years now, and it'll be the charity's birthday next month. And the aim of the charity is to be a support to those who suffer from nephrotic syndrome. That's both adults and parents with children, and also carers of children too. And so we try and provide as much up-to-date information as possible. Also try and let people know what clinical trials are happening in the UK and internationally. I personally myself, and I've got other people involved as well from the community to be involved with any research trials that are going on with researchers. I also help researchers with their work as much as possible, and that's both nationally and internationally. And I try to go to as many conferences as well to inform myself what's going on. And also, importantly, the charity fundraises for the research which is happening in Bristol. But although the research happens in Bristol, it happens all throughout the UK as well, as many of you know. And there's important research studies going on at the moment with Nurture and Nephros. And Maryam has kindly said if there's any questions you want to direct to her over the next couple of hours, you can do about Nephros and Nurture if you don't know anything about that as well. So that's me, that's my introduction. And so if I could kindly ask everybody on the panel to introduce themselves. I did give a little list, and hopefully everybody saw it in their email this morning. So
Wendy, sorry to interrupt you. Sorry, Wendy. We have about 56 people on the call today. If you're not part of the panel, can you please mute your call? And can you please take your video off so that we don't get disrupted through the meeting, because it's being recorded for the Nest website as well. So if I could just kindly ask those of you who've joined who are guests and not on the panel to please mute yourself and take the video off. That's really appreciated. Thank you.
Yeah.
Hopefully everybody got that from Maryam.
No, don't.
So if
you
you
mute to mute it and take the video off.
Video,
please. 60 people on it, so it's only people on the panel that on the video.
That'd be fantastic, because we're recording.
They don't want us muted, or they don't want us being asked.
Sorry, can we? Yes, thank you.
And also, any questions, if you can put them in the comment box, please. That's fantastic. I think we're there now. So if I could kindly ask the panel to introduce themselves, and I'm going to ask Rachel to introduce herself right at the end, because Rachel's going to kick off with some slides, some fantastic slides, which is shown to another charity group called Alport Syndrome charity group. So that'd be fantastic. So if I could ask Yincent to introduce himself, and I don't know you very well, Yincent, so be interested to hear about yourself. Thank you.
Hello. Hello, thank you for inviting me. I'm Yincent Tse. I'm a children's kidney consultant from the Northeast, and I'm the secretary of the British Association for Paediatric Nephrology. And over the last 3 months, really, we've been consulting with all these 13 kidney units, as well as many of our district general hospital colleagues, into how best to share information with families. And we've been doing consensus guidelines for shielding. So I'm sure some of you may have questions for that. So thank you for inviting me.
Thank you. Martin, are you there? Martin Christian? Are you on the call yet, Martin? Could we go to Hazel then? Hazel, could you introduce yourself?
Hi, I'm Hazel. I work at Great Ormond Street Hospital. I'm one of the clinical nurse specialists in renal, and my area is nephrotic syndrome. I started in the job about 7 years ago now as a nurse specialist, but I've been in nursing for 18 years, most of them spent in renal in various ways. So yeah, so I've been to 2 of the patient days before, spoken at one. So it's good that we can still have these meetings even virtually, like everything is at the moment. So nice to meet you all.
Thank you, Hazel. Thank you for joining us on your day off, I might add. Thank you very much. Sian, could you introduce yourself, please? Sian, not with us either.
No, I am sorry. I was.
That's all right. That's okay.
Reaching for the unmute button. I'm based in Cardiff, and I look after adults with kidney disease, including nephrotic syndrome. I look after people with disease both in their native kidneys and also transplant recipients. I run the young adult transition clinic with one of my colleagues from children's medicine, and I look after women who are pregnant who have kidney disease. In the usual course of events, I do a lot of recruitment to clinical trials. So both observational trials such as RADAR and encouraging people to sign up to that, through intervention trials. And at the moment prior to the COVID situation, that was involving both investigator-led start trials and also those of new agents under development by drug companies. A lot of my work over the last 3 months has been management of the situation with COVID, and being a transplant unit, we closed during the pandemic and are now shortly going to be reopening again. So if anybody has any specific questions around transplantation, that's taken up quite a lot of my time recently. Thank you.
Thank you, Sian. Ania?
Hi, I'm Ania Koziell. I'm the lead for nephrotic syndrome at Evelina Children's Hospital in London. So half my life I'm looking after complex nephrotics, and the other half of my life I do research on genetics and the immune system involvement within nephrotic syndrome. But also I'm leading on this trial of a treatment called liposorber, which is LDL apheresis in very complicated nephrotic syndrome. And I suppose I also speak from, regarding COVID, a little bit of experience from having a highly vulnerable individual at home who we've had to shield. And so I understand the challenges of trying to do that, particularly with 2 teenagers and a very grumpy 20-something-year-old at home as well.
Thank you, Ania. Have we got Kjell on the call yet? Kjell, are you there from Great Ormond Street?
Yes, I'm here.
Hi, Kjell. Long time no see.
Nice, my name.
Yes.
It wasn't too bad. I'm Kjell Tullus, and I'm a consultant pediatric nephrologist at Great Ormond Street. One of my interests that we were asked to say is, of course, nephrotic syndrome, together with inflammatory kidney diseases, hypertension, and urinary tract infections. And what I think over the few hours, I think would be interesting to share with you is a little bit data that we published recently on which is the best way to dose rituximab, which is one of my main interests. And we also recently got, I hope, accepted how it is with rituximab when you do repeated doses up to 7 courses in the same child. And what I also think would be interesting to share is that we've done a global study, really global, where we sent out 4,000 pediatric nephrologists and asked to collect data on how children on immunosuppression do when they get COVID. So we collected some 75 such children from everywhere, from Peru to Japan. So I could share that a little bit later. And we also published a few weeks ago a review on how tacrolimus and cyclosporin works in children with genetically confirmed steroid-resistant nephrotic syndrome, which is, of course, a really controversial topic, and where we now are launching a further study into that. So whenever you want me to say anything about one of these topics, I'm happy to do that later. Thank you.
Thank you so much for joining us. Thank you. Is Ben on the call from Scotland?
Yep, I'm here. So I'm Ben Reynolds, one of the consultants based at the Royal Hospital for Children in Glasgow. I'm mainly here, I think, to help to provide a little bit of guidance on how Boris and Nicola are disagreeing on the approaches to take, and how the Scottish situation differs from a lot of the rest of the UK. But happy to chat about anything. And I'm in my garden, so I do apologise if the traffic noise gets too much. I can go inside.
I can't hear anything at the moment. It's fantastic. I thought maybe you were on holiday somewhere with the background you've got. Okay, that's lovely. Thank you very much. Is Martin with us yet from Nottingham?
Hi Wendy, I'm here. I'm sorry I was a bit late.
No, I apologise. No, don't apologise. That's fine. That's fine.
So I'm Martin Christian. I'm a consultant paediatric nephrologist in Nottingham. I am leading on the PREDNOS group of studies at the moment, which the study in process is PREDNOS 2. And if it weren't for COVID, I would probably have some results to be able to share with you at this point. So PREDNOS 2 was a large multi-center study using patients recruited from about 100 sites around the UK, and just children, but testing to see whether giving a low dose of prednisolone every day for 6 days at the time of a cough or a cold, what we call an upper respiratory tract infection, prevented a relapse from occurring. Unfortunately, the COVID lockdown came just at the time when the final data queries were being chased up, and that meant that everything has had a knock-on effect in terms of the results being available. So we're now looking at the results being made available to the research team in September, and hopefully after that they'll pass into the public domain. So I think the next opportunity we have for one of these sort of national meetings, it would be a great opportunity to share those results, but we will be sharing them with everybody who participated in the study. And I imagine there probably are some parents on the call whose children went into that study. In the meantime, we have been trying to set up another large multi-center study to look at the dosing of prednisolone to give in a relapse. Again, it's a pediatric study, although I think that the results may be of relevance to adults that have got minimal change disease as well, and testing what Great Ormond Street have done as a sort of a retrospective case series and changed their practice, and are now dosing stable patients with a dose of prednisolone to treat a relapse in less than what the conventional dosing is. So this would be a large multi-center study to test that and to see whether it is there is good evidence to change practice much more nationally and internationally. So I'm happy to answer any of those questions on that. I suspect there are many others around the table who have got experience with COVID and things, and I might defer that to the likes of Yincent and Ania and others.
Thank you very much, Martin. I'm not completely sure, was Monique joining us as well today? Monique Bergen?
I've heard from her by email, and I know that she knows about today. I'm sure she'll jump in a minute if she is on the call. I haven't seen her name,
I think she would have
a lot of people
said hi if she was on the call.
Yeah.
No worries, no worries. Then, okay, so could I ask Professor Rachel Lennon to kindly introduce herself and perhaps proceed with the slides?
Yeah, sure. Thank you, Wendy, and thank you very much for the invitation to join you today. It's a real pleasure. So I'm based in Manchester. I'm a consultant paediatric nephrologist at the Royal Manchester Children's Hospital, and I have a particular interest clinically in a condition called Alport syndrome, but also see a number of children with nephrotic syndrome too. The other part of my role is based at the university, where I lead a research team in the lab, and we've just managed to get back into the lab this week, which is good news. And in the lab, we're really interested to understand more about the basic science that is behind problems that develop in the kidney, and in particular diseases like nephrotic syndrome. So I've just got a few slides, 4 or 5 slides, just that might help us to get onto the same page in terms of what we're talking about today, and also might just stimulate some questions or thoughts around COVID-19. And these were slides that I prepared actually for a patient information session in May time. So things are definitely changing, and it's certainly going to be interesting to see some of the questions that we hear from everybody today. So let me just see if I can share my screen. There we go. So can you see my slides there?
Yeah, that's lovely. Yes,
Okay.
I can see them. I can see them well. Yes.
Okay, here we go. Brilliant. Okay, so so let me first of all introduce you to our amazing kidneys. Most of us are born with 2 kidneys. They sit either side of the main blood vessels in the abdomen. And if we zoom into the kidneys, we see these structures called nephrons, and we have about 1 million nephrons in each human kidney. Then right at the very first part of the nephron is this structure here that we call the glomerulus, or the filter. So this is a cross-section view of the kidney filter. And as I say, there's 1 million nephrons. We've got around 1 million filters, or tiny filters, in each of our kidneys. And these, we're born with this number. We don't grow anymore during life as humans. But these filters are critical in terms of their function in the kidney, and also really important when we think about nephrotic syndrome. So if we zoom in again just to this tiny blood vessel here, and the wall of this tiny blood vessel looks like something like this, where we've got some pink cells on the inside. These are called endothelial cells. We've got these green feet of podocytes on the outside of the wall, and then we've got this structure here, which is called the glomerular basement membrane. Overall, this structure is called the filtration barrier, and it's the barrier that prevents us from losing blood cells in our body from within the circulation out into the urine. So this wall is the filter, and it helps to keep large things like cells and large proteins inside the circulation, and prevents them from leaking out into the urine. So if we just move on to the next slide, I'm showing you there on the same picture there of the kidney filter, and this is a healthy normal kidney filter. But what happens in a number of different diseases that affect the filters is that the cells, in particular these podocytes, change in their appearance. And so we go from a healthy looking capillary and a healthy filtration barrier to something that looks a little bit like this when we look under the microscope from kidney biopsies. And in here, the green cells have changed quite dramatically. So these podocytes look very different. We can also see a number of different changes to the other cells and to this basement membrane there in the structure as well. But the key change actually in nephrotic syndrome is with these cells, the podocytes. And when we see this on a biopsy down the microscope, this will always be accompanied by loss of protein into the urine. And of course, many of you will be familiar with the urine dipstick tests that we use for monitoring proteinuria. And in nephrotic syndrome, the amount of protein that leaks across these filters is huge. And as a result of that, there's less protein circulating in the body, and the body can develop swelling or edema as a result of low levels of protein. So if this process continues and we're not able to switch it off or to create remission or induce remission with medicines that we use, then we do see a consequence. We see that these healthy, normal filters turn into these filters where there's lots of scarring. And when we see this appearance on the kidney biopsies, then this is often associated with loss of function, loss of kidney function. So all of our efforts in terms of research labs, not only in the UK, but all over the world, are trying to figure out how we go from this healthy capillary to this abnormal capillary, so that we can pick things up and intervene at the critical point and send the filter back in this direction to a healthy, normal structure. So just along the bottom, I've indicated some of the clinical signs and treatments that we use for in the context of nephrotic syndrome. So of course, proteinuria is one of the really key important features that we monitor for and want to improve in nephrotic syndrome. We may use immunosuppression drugs to suppress the immune system to control nephrotic syndrome. And in some situations, when the treatment isn't as effective and we're not able to switch off that protein leak, then there is a deterioration in kidney function, and some patients will go on to need dialysis and transplantation. So that's just a really, in one slide, nutshell introduction to the kidneys and nephrotic syndrome. But of course, today we're thinking about the aspects of this new coronavirus that we've known for less than 7 months, and the disease that it causes COVID-19. So on the next couple of slides, I've just got really some bullet point pieces of information that could perhaps help stimulate some of the discussion this morning. First of all, we should say that the risk of this new virus, SARS-CoV-2, to children is low, and across the world, in all of the countries that have been affected, low numbers of children and young people are requiring hospital admission. So that's important to know. There's a really if you want to delve into more detail, there's a fabulous website which is really good for pediatrics and is just gathering lots of the information that's coming through all the time on COVID-19. So I can share these links with Wendy, and people can follow those up if they want to get into some of the more
that'd be lovely.
detail. There is an inflammatory syndrome that has been reported in children that is very rare, but is thought to be in response to having had this infection. So we're certainly learning more about that condition as the weeks in our experience so far, and we'll learn more as time goes on. I guess one big factor for children and adults throughout this whole pandemic situation is that we have seen people concerned about coming to hospital, and so non-COVID problems have sometimes presented late, and that can then affect the types of treatment that we can give and the effectiveness of treatment. So it's really important to remember that you know, the health service is still there to support people when they are unwell. Shielding, I won't mention too much about this, and our real expert, I'm sure, on the panel is Yincent, who's done an awful lot of work together with other colleagues, but we have got recent and updated guidance in terms of shielding. There has, certainly in Manchester, we experienced a big discrepancy in terms of the notifications that came out centrally from the government and our local advice, and with regard to shielding, I would certainly recommend that people contact their local centres for individual advice if there are questions. School, really clearly so important for the paediatric age group, and we've now seen schools reopen for some children. Again, in terms of those individual plans and what is right for your child, that's certainly something that we're looking at the individual level for patients, and so discussing that with your clinical teams. Final slide is just to mention a couple of things that have been discussed have come up in the media through the pandemic, or else have just raised discussion. There's a group of drugs called ACE inhibitors, and another set of drugs called angiotensin receptor blockers. They work in a similar manner, and there is a connection to the pathway that they work on in the body, and this how the coronavirus is thought to work. And so that raised the question whether it was safe to continue this particular type of treatment in the current situation. And certainly the recommendation is to continue with any current treatment plans that you have using these treatments, because the evidence certainly isn't there to suggest one way or another. And again, if people want to delve into the detail, there's a great summary on this site. Transplantation, so Sian mentioned she's had a lot of involvement in the transplant related aspects that we need to now consider with COVID-19. Most UK programmes paused during the pandemic. I think there were only a couple of centres that remained open, and that was because it was safe for that to happen. And most units, I would say, now are in the phase of considering their options for restarting, and some have reopened. Final word is on research, and as Martin mentioned, a lot of clinical trials have had a pause in terms of either being able to do data analysis or recruit patients into trials. Again, once that's safe to do so, certainly in terms of the recruitment and any face-to-face contact with patients and families, that will restart. I think a really, really negative consequence of the whole situation is the reduced income that charity funders will and are experiencing. That's certainly resulted in postponed deadlines for funding applications, and that's been coupled together with closures of universities and laboratory facilities. So there's no question that research has taken a significant impact, but actually within the community, people are really keen to maintain the momentum, and part of that is being able to connect in these new ways, these virtual ways that we can now connect all over the world. So we have to think about some of the positives that come out, but recognise that research will have been affected. I do just have one more slide, and that is just to remind me to say that actually we would have been hosting some part of this meeting in Manchester face-to-face in June, had we gone ahead with the original plan to host the 13th International Podocyte Conference, but you won't be surprised to hear that that was postponed. But we do have a new date, or a new week. It's July next year, and it would be wonderful to continue working with Wendy to see how we could link in the main scientific scientific meeting with a planned patient meeting on the 31st of July next year. And what we're likely to do is have a hybrid meeting where we have an in-person option for people who can travel and attend, and then also a virtual live streaming option otherwise. So I'll stop sharing my screen there and hand back to Wendy.
That's wonderful. Thank you very much indeed, Rachel. The wonderful slides. Thank you. Yes, and it would be very helpful to have those links you suggested earlier on to share with everybody. Thank you. So I'm starting to have some questions put in the chat box. If you haven't put a question in so far, please feel free, Nest family, to put a question in there for me, then I can direct the questions to the panel. So I think the first question from Rachel Ravenhill is that, you know, many families, including herself, being very frustrated by the conflicting shielding advice. The government have been putting out letters to everybody, and then those letters, I might add, are very valuable to people because obviously they can show employers that they've got to shield their child or a loved one, and most employers have been sympathetic, and they've either been given the time off or furloughed so they can shield their loved ones. Some not so good, and also it's a bit of a golden ticket as well, because it's meant that people have been able to call upon the supermarkets to deliver their shopping and everything. So that's very important. However, there was one or two centres were a bit reluctant to give out letters, especially to the paediatric community, because of the data that was coming out of South Korea at the beginning, to say that children weren't at such a risk, and then they were telling patients and families not to worry, not to worry. But having the letter was critical for the families to have. So I don't know if everybody can bear that in mind and pass it on to everybody else. And we had a lot of questions around that on our busy Facebook page. So I wondered if I could call upon Yincent to talk about shielding, and then maybe afterwards ask Ben and Sian to share afterwards about the shielding advice in Scotland and Wales, please.
Yes, thank you. Yeah, so shielding has been a very difficult situation. So shielding is a very blunt tool to protect the most vulnerable in society. So I mean, I'll tell you the background of what happened over the last few months, just to put it all into perspective. And I share many of your concerns about the conflicting advice, the sort of random letters that people get. And it seems to be a kind of all or nothing situation. So what happened was that back in March, when the pandemic started to strike in the UK, especially in London and West Midlands, is that there was very quickly the country had to get itself ready, and there was more and more data coming from other countries that a lot of people were unfortunately getting very sick and dying, and that's predominantly in the elderly population. However, we didn't know that at the time, because this, as Rachel said, this is a very new disease. And what happened was that within one weekend, medical societies were asked to give guidance up to the chief medical officer to inform the government about who should be shielded, because virtually all children's departments did was to collaborate with their adult colleagues, because we didn't know much about the disease at that point. Although we had a hint that maybe it was better, we just didn't have enough data. So everyone thought, okay, we'll just align with the adults, and that's how the original shielding guidelines came in. So, but actually, the shielding guidelines, there were two main groups. One was that for transplant patients to be shielded, and the other one was that for patients who are on immunosuppression, which is our nephrotic patients, on significant amount of immunosuppression to be shielded. What wasn't stated though is how much immunosuppression people should have before they were shielded. So each group had to make up their own thresholds, and that caused quite a lot of confusion. So together with the Renal Association, we standardized what we said, and maybe respectively that was too much, but I'll show you some. Do you mind if I share some slides?
That'd be lovely.
Yeah, so I'll show you a few slides. Okay, so this is some. Okay, so this is the data about people who unfortunately died of COVID, and this is data from England from just this week about everyone who died. And unfortunately, as you can see, that it's predominantly the elderly. Actually, it's not just of the elderly, because there's a smartening of younger people.
Yincent,
hello.
Could I ask you to speak up a little bit? I think we keep losing you.
Oh, sorry.
That's all right.
Yes, so can you hear me now? Yeah, so as you can see, the data in the UK is predominantly elderly people.
No. Yincent, could you higher up your audio a little bit more, please?
No, it might be, Yincent, that your hand is on the speaker of your laptop if
okay.
you're using it.
So. Oh, that's better.
Sorry.
Better.
Oh, yes, that must be it.
Sorry.
I'm just moving the mouse. So really, as I was saying, when the pandemic hit the UK, we didn't know which group of patients it was going to affect. Okay, so this is so it's predominantly the elderly. And also in the kidney population, we were seeing devastating numbers. And so this is the people with kidney transplant. And if you exaggerate, and the people on nephrotic syndrome sometimes have as much immunosuppression as those with kidney transplant. But reassuringly, the younger age group, especially in children and the young adults, don't tend to be that affected. So as the time went by, and also my colleague Kjell Tullus has good data as well internationally. So this is the this is data from children who are admitted to hospitals in England. It's not every hospital, but this is most hospitals in England. And if you look at the top left, starting from March
every
till
time
now,
you put your hand in front, we lose you.
Sorry, starting from March until now, if you look at the top left, you can see that there was a smartening in March, and actually over the last 2 months, the number of children going to hospital with COVID have dropped off. The bottom left shows what comorbidities that they have, and actually there are very few children with kidney disease in the comorbidities. And in the right panel is if you're a child and you do go to hospital, very, very few, fortunately, get so ill that they need intensive care. So in the last few weeks, after consultations with our colleagues around the country and with some patients as well, we've come out with our new shielding guidelines. We felt it may be useful to have an intermediate group. So we wanted to minimize the number of people who are shielded, because unfortunately, if you're shielded, then the advice is not to go to school. And a lot of our patients were telling us that their children were getting more and more problems, such as mental health problems, with with staying at home and not being able to go to school. And I mean, I've got 2 children of my own, and one who's in year 6 just went back to school a couple of weeks ago, and schools are doing a lot to keep children safe. So it's not only that the data shows that children are fortunately not very affected, even though they're quite immunosuppressed. The other thing is that I think parents need to feel safe about going back to school as well. And so that's how we came up with this shielding guideline. So I'll just stop there for now. Oh yeah, so the other thing is that a lot of patients were getting letters about shielding, and that's because right at the start in March, the NHS took big databases. So, for example, if you're on some certain medicines, such as immunosuppression, or if you're on a transplant list, then you automatically go into this big database of nearly 2 million people to say that they were shielded. So we found that there were some patients who maybe were on medicine but no longer were so, or some patients which were unfortunately coded wrongly. So they may or may not have received letters, and I think that's where a lot of confusion also came from. Any questions? Wendy?
I haven't got any further questions. One of the questions I had a lot from people, and I know, and people still ask, is yes, those who were very, very immunosuppressed they realised they needed to shield, whether they had a letter or not. You know, common sense told them they must shield their loved one. But what about those who've just come off of immunosuppression, say after a few months?
Hello?
Hello? Can you hear me?
Hi, Wendy.
Hi.
Hi. Yes, I can hear you now.
Oh, you can hear me now.
Yes. So the thing. Yeah. So we don't actually think that people on immunosuppression are even more likely to get ill with COVID, and that's in children. However, I think there was some reluctance to fully de-shield everyone, and that's from consensus around the country. And perhaps my colleague Kjell Tullus can help with this.
Yes, that'd be lovely. Thank you. Thank you very much. Well, Kjell, could you help with the question as well? What advice did you give to patients, that those who are not immunosuppressed but come off immunosuppression recently, say up to about 6 months, because I felt they were still at a risk?
Could I tell you a little bit about the study?
Yes, that would be lovely.
And actually, the science also Afzal guys study as it emerges.
Yes, that'd be lovely. And sorry, one other thing. Obviously the infections are lower now, and hopefully they stay that way. And obviously we're all worried that there might be a second wave and everything. But of course, people are still relapsing. So obviously they'll think, well, I can stop shielding now, but then they relapse. So when they relapse, they should shield. Now, some people have had conflicting information about that. Some have been told not to worry. And I was concerned about this, and I asked them to get back to the clinicians and check. And some did and said, oh, actually, no, we've got to shield. So is it correct they should they should, even though shielding, the government have said don't shield, that you should shield. You should shield if you relapse.
Can I give you my picture? Yeah.
Yeah, absolutely. That'd be fantastic. Thank you.
You know, when we sort of end of February, early March started to realize that this was over us, of course, we all got very, very worried about this. But there were 2 or 3 things that we learned very early on that made us a little bit less worried. And one was that, as Yincent showed, that children all the time in every country seem to have been in a really low risk group just because they are children. And the other important thing was that actually the severe thing that happens in the rare children and in adults is that the immune system goes on overdrive. So they get like nearly an autoimmune reaction. And as you learned in the press, the treatments that now are starting to become successful against COVID are all immunosuppressive treatments. Not exactly the same that we use in nephrotic children, but there was a huge study showing that a low dose of steroids reduces mortality in adult patients with a third. So, which would answer your question, there's no reason to believe that treating a relapse is bad. But let me also tell you about the study. In early March, we made a survey, which we have sent out through an organization we call ERCNet, which covers many pediatric nephrologists in Europe, and also to organizations for pediatric nephrologists, both in Asia and IPNA all over the world and in Europe. And we sent that out to them now. I think I did the last one yesterday, because we now decided that we will stop this study because we got enough data, we think. And we sent it out, I think, 8 or 9 times. And there are, I think, 2 important messages that emerge. One is that, which could be a bias from the study, is that we collect relatively few children worldwide. We are up to something between 70 and 80 just now. And we are not only looking at nephrotic children, but also at transplanted children and children with glomerulonephritis, which also has the same kind of medicine. So, it seems to be that the numbers of the children that get COVID is low, and that also supported by many other studies around the world. And secondly, they seem to do well. We published the first 18, which is a low number, and they all did well. Now when we are up to close to 80, we actually had 2 deaths, both in Peru, in Lima in Peru. One didn't have a proven COVID, but symptoms of COVID. And the other one had a sepsis with a very severe bacteria at the same time. All the other children have done very well. And I'm just now writing up this paper. So I've really gone through a number of 100 of papers from the literature, which is emerging sort of on a daily basis. And the interesting thing is that this is the same pattern in rheumatology patients who use the same kind of, and also in adults. And the other drugs that seem to work in adults, again, except steroids, is, for example, what we call TNF alpha blockers, which is not a similar, but a not, also suppressing the immune system very much, and that reduces mortality in patients with Crohn's disease, which are the main who have them. And also when you block IL-6, it seems to reduce. So there are a lot of things coming up, including our study, that tells us that we don't need to worry about children with nephrotic syndrome and immunosuppression. And if something, these drugs are protective. And that's, of course, And I understand that these different messages really are enormously confusing. But I think that's something that always happens when something very new is thrown at us. And I think it's natural that we early on react and try to be very protective. And that's why, of course, it makes it difficult that, well, for people, of course, to see that they get different messages. I really appreciate that.
Well, that's fantastic news. I'm sure everybody will be relieved to hear the results of the survey. Ella is asking, is there data on whether or not COVID-19 is causing relapse in nephrotic syndrome?
I think it's very
one of the few, sorry, Ania?
Yeah, we've had a couple of cases where we think the patients had COVID. Both were on immunosuppression, on tacrolimus rather than prednisolone. Both got the rash, but didn't get a relapse. I think one of the very big problems is that we're dealing with nephrotic syndrome, which is a relatively rare disease, but we're also dealing with a virus that the government very much modeled initially, at least, on a flu virus, and this is really quite something different. So I think the data is very much emerging, which is frustrating for knowing exactly how to plan things. Nonetheless, I think that's why sometimes it's a little bit difficult to know exactly what to say. All I know is that COVID can cause kidney disease, that's for sure, certainly in adults. But whether, if you already have nephrotic syndrome, whether it can cause a relapse, I think the data is just not out there at the moment. It's just difficult to answer that question. Nonetheless, of the two patients we've had, they both got COVID foot, we think, but not a relapse together. And they're both quite complex nephrotics. They're not just sort of people who aren't on any immunosuppression or have mild disease.
Thank you, Ania. That's helpful. Thank you.
Oh, can I add something? Oh, interesting. In the last few months, because the number of children mixing is less, we are seeing less relapses as a whole. But I doubt COVID. I mean, we don't have the data, as Ania said, but it doesn't seem like that it's a particularly linked to relapse in nephrotic syndrome in the patients that I've seen.
I think just one thing we'd say, because we obviously in London, we were hit very hard, very early. Possibly none of us are naturally Tory voters, so they didn't care, I don't know. But, you know, we can wax lyrical about whether they should have shut down the country two weeks before they did. Nonetheless, I think what we have observed is a far greater incidence of nephrotic syndrome patients presenting for the first time than perhaps we would expect at this time of year, bearing in mind it's not winter, it's spring. Whether that's linked or not, I don't know, because at the moment we can test ourselves whether we've had COVID or not, but not our patients as yet. And again, the test is not 100%, because I've got colleagues who have evidence that they had COVID in the sense that they tested positive on swab, but some months down the line, the IgG is not positive. So it's not a fantastic test, but one of the things we do plan to do is actually test all our patients to see who may or may not have had COVID. And that's particularly the shielded population, because that would be a very interesting question to answer, because however shielded you try to be from personal experience, you can never be 100% shielded. It's just not possible, and to survive psychologically.
Yes, thank you. Yes, it is very difficult, isn't it? Because usually one person, it's very difficult for a whole family to shield. Families have done it. I know some families have done it very extremely well, but you're very dependent on the people around you. So yes, that is very difficult. Ania, I noticed you've replied in the chat box about advising on dosage. So are you giving your patients a lower dose then if they start relapsing, or is that what you're saying? 30 minutes?
I've just taken that straight out of the BAPN or the Reynolds Association guidelines. I mean, we tend to modify the protocol depending on the patient. So of our patients who may relapse, we don't always do full dose, but that's got nothing to do with COVID. to do with the way the patient responds.
Okay, so
the question about could COVID cause nephrotic syndrome? It can do in adults, but we don't have the data yet in children. It causes a particular form of nephrotic syndrome curve collapsing, FSGS, which is quite rare. But actually, of the 3 adults I've been involved with, all of them have actually got over it, and with prednisolone, and their kidney function has been okay.
Okay, thank you very much. Thank you. Just before we go to Ben and Sian, could I ask Yincent the question: if there's a second wave, will shielders have to shield again, or will you go off the current data and keep people in the groups, e.g. from high risk to moderate?
Well, I mean, I think as Kjell has very nicely put, that we don't think that children on immunosuppression are particularly likely to get ill with it. So I think one of the things is that it would be unlikely we would change the shielding criteria, even though there's the second wave, because it's about well, so the second wave would mean that maybe you're more likely to catch it because there's more around. However, I think the country will be better prepared for a second wave, and if a child does get COVID now or in a second wave, the data seems pretty reassuring that the majority won't particularly get ill.
Okay, thank you. Thank you very much. Could I ask Ben to share with us what the shielding advice for Scotland is at the moment, please? Thank you.
I think that the shielding advice in Scotland is complicated, because it really shows you how government advice is partly based in party politics versus what is actually of benefit to the health of people. And I'm in a fairly unique situation in that my partner works for the Scottish Executive, and so I have a little bit of insider info about some of the decisions that are made. The advice that we have provided to our patients and to the Scottish Executive was the BAPN guidance that patients don't need shielded unless they are within first 3 months of transplant or on high dose steroids. And so all of our nephrotic patients who are on tacrolimus or MMF or levamisole do not need to consider themselves as shielded. The Scottish government advice remains at the moment that you are to consider yourself shielded if you are transplanted at all ever or on a combination of immunosuppressive medications. They don't specify a dose of steroids. Now that discrepancy comes partly from the fact that the Scottish Executive is being very, very cautious, and as I'm sure many of you are aware, the lockdown situation in Scotland remains tighter than it is in England, despite the fact that we were hit nowhere near as hard as down in London, had far fewer cases, and it has been much less of an issue here. We remain much more restricted in what we can do, and there are political decisions that are made when providing advice to families about where, and essentially the Scottish Executive has taken a very cautious approach because they do not want to be accused of loosening things up too soon and putting people at risk without perhaps considering the mental health implications and the society implications for the families that are doing this. The get out clause that they then put at the end is that this is government guidance. It is not an absolute, and they are recommending that people shield, but they're not saying that they have to. So that's their get out if people then say I have mental health issues. So I think that's partly where some of the conflict comes in the advice. So if I am a transplanted patient in Scotland, my nephrologist is telling me I don't need to shield, but the government is telling me I do. That conflict can be quite, and the same is true for if I'm a patient with nephrotic syndrome who is on a low dose of steroids but also tacrolimus. My advice would be, well, actually you probably don't need to shield but you are clinically vulnerable and you should be careful when you go out. But the Scottish Executive stance currently is that those patients should be shielding. So that's where the conflict comes, is that the government has votes to consider, and how they're going to look in the next election, and how many children have died from COVID-19 in Scotland will be a voting issue, whereas the mental health of all the children that are required to shield probably doesn't sound quite so interesting on a voting campaign. And I think that's very important to bear in mind, is that the government guidance is meant to be based on what medics say, but at the end of the day, it is what the government decide to say, and it is not all based in science.
Thank you, Ben. Thank you very much. Yes, that's something we all need to consider, is that our mental health for our families and loved ones. Could I go to Sian now but if you could share what the shielding advice is for Wales, please.
I'm going to broaden it out slightly rather than specifics of shielding, and a lot of what my colleagues have said resonates with our approach there. When we were facing this very new virus and threat to health earlier in the year, we were very broad about advice for shielding and avoiding social contact, because we didn't know how this was going to play out in the different potentially very vulnerable groups. So our shielding recommendations were very broad, and as somebody said, the particular advantage of that was to allow vulnerable people to access home delivery of shopping, to have evidence that they would not be expected to be present at work, and it was to protect people. And I think we've then had a window to assess how vulnerable people are in those different categories as we come up to thinking about relaxing lockdown and relaxing shielding recommendations. So in Wales, we have been more stringent than England and more along the Scottish lines. And also in terms of relaxing our lockdown arrangements, we're being much slower than both England and Scotland. And we haven't yet set a timetable for returning to general activities. I think the guidance for all of these restrictions is going to depend on what the community prevalence of the infection is. And we have a much better handle on this now with the testing method, testing approach, than we did early on in the epidemic, when we had a period that symptomatic people were asked to stay at home and we weren't testing, we weren't contact tracing. We really had very little idea what was going on. We now have a much better idea. So we know in Wales at the moment that we're dealing with 3 outbreaks, 2 in association with meat processing factories and 1 in association with a healthcare facility. So we have a very good idea of where these hotspots are, and I think that's going to be very important going forward for managing risk. And then in terms of people who are shielding and vulnerable who are coming back out from that, I think the really important things to consider is that to get the infection, you have to have contact with somebody. So there need to be people in the community who have the virus at the moment, and then your likelihood of acquiring the infection will depend on how many different people you're seeing, how close you are to them, and how long you spend in contact. And we're talking about this a lot in the adult setting at the moment, because of people wondering about safely returning to work and what changes need to be made in the workplace, which is similar to the situation faced by schools, but almost more crucial for adults who are that much more vulnerable to infection and severe disease. And the influence of age is quite striking in every group. So for transplant recipients who are generally vulnerable because of their immunosuppression, that their risk dramatically increases with age, and it is potentially a serious and life-threatening illness. the shielding recommendations in adults are different to children, so we strongly recommend all adult transplant recipients to shield at the moment, and will need to take particular precautions when society opens up, because they are a particularly vulnerable group. So that's sort of my perspective on shielding and relaxing shielding going forward, and the factors that will influence the way we approach it.
Thank you, Sian. You're also going to share with us about transplantation.
Oh yes.
Would you like to share that?
Yes. So again, at the beginning of the epidemic, there were so many unknowns and cases increasing very rapidly, and the majority of kidney transplant patients, kidney transplant units, suspended their programs. The units that continued were those that were also doing liver transplants, which is a much more urgent, life-saving transplant than kidneys usually. So the liver units, most of them managed to keep going through the pandemic. There were other units who did not have acute admissions to that hospital site, so it was much easier to keep the hospital free of coronavirus than hospitals that have an emergency stream. So units such as Oxford were able to, I think, pause temporarily and restart quite quickly. And then there were other units such as Belfast who moved their transplant activity to a private healthcare facility early on, which again had no emergency stream, and so they were able to continue as well. So there are usually 23 adult transplant units, and I think 6 were able to continue, and units are now gradually opening up again. I think Great Ormond Street has opened and has done a paediatric transplant, and in London it's been particularly difficult because of the number of infections, but slowly units are opening up again. Most units are opening to deceased donor transplants in the first instance rather than living donation. Another group that's particularly vulnerable to severe COVID disease are those who are post-operative, and there's been a lot of concern about living kidney donors acquiring infection in the post-operative period and becoming very poorly as a result of that. So there's been a lot of anxiety about ensuring safety in the pre, peri, post-operative period, both for the recipient and also for the living donors, which has had a big impact on paediatric transplant programs where a lot of the donors are living donors.
That's great. Thank you for sharing that, Sian. Thank you very much indeed. Thank you. I just want to check the time because I did say we'd have 5-10 minute break, but let me just check. Excuse me. If everybody's happy, if we could have like literally have a 5-minute break, and then I'll come back and ask some more questions, which I've got in my comment box to everybody. So if we could all just have a quick 5-minute break and we just grab a glass of water, is that okay? Or a cup of tea? Would that be good? Okay, thanks.
That's good.
Okay. there's many questions to get through, but I can see Ania and a few of you already replied to some of them. Thank you so much. There's still some outstanding questions about shielding. I have one from Ruth, and I'm assuming it's somebody, her child's in England. So could I kindly ask Hazel if she wouldn't mind replying to this question, Ruth's question, because obviously she's probably been given lots of advice about children going back to school. Have we got Hazel with us still? Hazel Webb from Great Ormond Street. I don't know if you saw the the message from Ruth. Her son is returning to school on the 6th of July for 2 days, feeling a bit confused as to whether he should go or not. His sister has been back since May half term. Is there any guidance for returning to school?
Yeah, generally we have been advising children to go back to school when their schools are being reopened, unless they fall into that. So we've been using the BAPN guidelines generally throughout. So the ones that are extremely clinically vulnerable, so the post-transplant in 3 months or receiving currently IV immunosuppression, the ones we wouldn't advise to go back to school at the moment. But generally, most of the children we have been encouraging to go back to school. And for a lot of my patients and a lot of my parents have expressed actually that is what they want for their children, because they feel being at home and the mental health of their children, the difficulties of homeschooling, etc. We've had some inpatients on a lot of immunosuppression, so transplant immunosuppression, if you like. We've encouraged to go back to school, but actually that balance of risk versus the balance of benefit of going back to school, we feel the balance of benefit is much higher for most children. So we have encouraged most children to go back to school.
That's great. Thank you. Thank you. You may also ask, this is a question for me. One of the questions I had for my Facebook group, and it's really difficult, and I'm sure for many of you, maybe yourself is affected, I don't know, or you know lots of families have been affected by this. Now, obviously, there's only a small percentage, but even so, it's been really difficult for those who actually work in the health service and actually got children who are very vulnerable. And sometimes, you know, NHS bosses have said, no, sorry, we can't put you in furlough. So that puts them in a very difficult position. Have you had any experience of this with your college, yourself, or your colleagues, or I don't know if you can give any advice on this, or if you can't, anybody else?
I haven't had any specific in the nephrotic syndrome patients. I know we've had some in our population, and generally parents have made that decision by themselves. We can only give the advice that we and advise them. For some parents, they've gone back to their bosses and they don't want to work. For some, they have carried on working, and that's meant leaving the family house and separating it that way so they can stay away from the more vulnerable. For some, they haven't taken it. So I think there is quite a wide, we can only give advice how parents and families, and there's so many individual circumstances that make up that case. If you've got a shielded letter, if you've got a shielded child at home, or probably more if you've got a shielded adult at home, then my understanding is that employers should follow that shielded guidance and
that's right
accordingly. So
that's right, because I kept referring people to the government website, and that bosses should adhere to that, but some of them are not listening, sadly. Sometimes people can be redeployed within the health service, which is helpful, but I just thought I'd ask, you know, on that.
We can only give the advice as we know it, and then I think families take that advice and use it as they see.
Yeah,
their own individual circumstances.
Okay, thank you very much. Thank you. So the other questions I've got in my box is, it was from Rebecca, is if there's a second wave, will shielders have to, no, we had that one, apologies. Kjell, I have another question for you. Genevieve is asking, for the study, was it all children with kidney conditions on immunosuppressants? I'm assuming it was, yes?
Yeah, it was. And I saw the question, they were all below 18. So they were all children and young people. And it doesn't seem to be any difference in risk in that age group up to 18.
Up to 18. Okay, that's lovely. Thank you. That answers Claire's question as well. Thank you very much. Okay, and I think Ania's covered Holly's question. Could COVID cause nephrotic syndrome in the first instance? She answered that earlier. Ania shared something with clinicians.
I'm just wondering whether there are quite detailed BAPN guidelines dated the 27th of May. I don't know what Yincent would think about this, but certainly we have been sending them out also to patients. Because sometimes it's kind of useful just to read, and whilst it refers to the government website, certainly I have found the government website not to be completely helpful, and it's, you know, you have to use a fair dose of common sense as to what you do and do not do, because the parallel of going back to work for an adult who's probably at higher risk than a child going back to school is there. But you know, you've just sometimes you've got to weave through. But I think that that guideline is actually quite a good way of paraphrasing and summarizing exactly what should be given out. But with clinics at the moment, a lot of them face to face, a lot of, well, rarely face to face, a lot virtual, a lot telephone. Sometimes the IT doesn't work. I just wonder whether we've got to maybe resort to more information via, say, email or posting maybe on the Facebook page. That would just really help people just get their heads around it. In the cold light of day, you can read something and then just go over it until you understand it. Whereas sometimes when people talk at you, certainly I don't understand always. So I don't anticipate that anyone else does.
Yeah, sometimes the amount of information on the page is just too much to take in, isn't it? Apart from the BAPN newsletters, which have been very helpful, the other site I signpost people to is the Kidney Care UK website. The information they put down there is very, very good, and it's in a lot of detail. And I find that easy to absorb. Yes, so that, yeah, thank you. Claire is asking, can a child on immunosuppression go to school if stringent social distancing is not possible, as this is likely the case come September, you know, in regard to sports clubs and activities? Should they participate in those activities or not, do you think?
I think it's really hard at the moment to say what will happen in September, because if we think what's happened in the last 2 months, things have changed and things are going to change over the next 2 months. Hopefully everything will continue to decrease. The amount of circulating infections in the community will decrease, so therefore that risk does decrease. So, and I'd imagine the lockdown will reflect that. So it's really hard actually to say. I think if everything continues to get better, then all those social distancing will naturally decrease anyway. But I think it's really important to say that schools are still children are still going to have the less infections, less at risk of the infections, etc. So it's very different if you've got adults going back to work and that risk. I don't know what anyone else thinks.
Okay, thank you, Hazel. That's helpful. Thank you.
Well, I mean, I think one of the benefits of getting good data, which we actually do have in this country, is that we do get daily data on infection rates, etc. So I think over the next 2 months, which is over the summer, we will get a much better idea of the infection rate. As I put in the chat box, there's 2 issues. One is how likely you are to get ill if you get it, and you could get it without knowing someone else has had it, and it's usually between a family spread. And then secondly is that how likely one is how likely you're going to get ill if you get it, and secondly is how likely you're going to get COVID. And I think the government is quite worried about how likely people are to get COVID, because as we've said, it's the more elderly people who are going to have a huge problem if there's going to be a second wave, and I'm sure our public health service will try to get on top of that.
Thank you, Yincent. Thank you.
I think there's a couple of points that certainly Sian raised earlier about you've got to look at your local infection rate. I think there's probably more risk of a second wave than less. However, we will know by September, but it may well be regional. And so the other thing I would say is just to look at this thing the government always push out called the R index. The lower that is, the less risk of infection in your local area. And it's going to be a little bit regionalized. I think the NHS Test and Trace app would help if it was working, but it doesn't. So you've got a little bit, see what's going around in your own area. But I think also Sian touched upon quite a few important points. Getting it is a little bit about viral load. So if you're in close proximity to someone who's heavily infected, whoever you are and whatever age you are, other than it appears that children aged 9 and under are at less risk, you may well get some sort of COVID. Whether you're going to develop disease or how badly you're going to develop the disease, because there's the one thing is just getting the virus anyway, and you may or may not get symptoms, but it's also the second thing that children manifest as this hyperimmune syndrome and adults manifest as the actual COVID. The other thing to say is that it's not like flu. It doesn't just affect your lungs. It can affect your kidney, your brain, your liver, and all other things. And that to some extent is a little bit genetically determined, because I'm part of a study where we're looking at a bunch of individuals that gave their DNA to the UK Biobank in good faith, completely healthy people, and about 750 to 1,000 of them then went on to get coronavirus unexpectedly. And they're in the demographic where they shouldn't have been ill and they were. So people are looking at whether there's any sort of changes, and it does look a little bit like the changes in your immune control box tend to dictate how you respond to viruses anyway. But that's unfortunately, that's uncontrollable. You can't sort of, and at the moment there is no test that is robust enough to tell who's going to get it or not.
Thank you, Ania. Thank you. Okay, so I'm looking at the inbox again about the questions, and I see one or two of you already replied in the inbox for me kindly, but I'm going to read them out because, as you know, we're recording this, so it'll be valuable to others later on. Sarah Davis' question was, do we know when immunosuppressant treatments like rituximab will start again, please? I was given my first treatments in October last year and was due another infusion in April. I'm worried about relapsing as I spent a month in hospital after my last relapse of minimal change disease. I realise that there are some treatments ongoing for more severe cases, but was wondering when they plan to become more mainstream again. And thank you, Ania, for replying to say that Evelina, in fact, you're unable to pause, you've carried on, and perhaps, and in some instances, just given one dose. So Evelina will continue with their treatments, and I know Rachel, up in Manchester, you've actually treated somebody with rituximab,
yeah,
and Ben is also doing the same. Because I know lots of people have been really, really anxious about going in and have the rituximab. and I obviously can't say the name for confidential reasons, but I know you treated someone, Rachel, haven't you, recently? But it's the anxiety about going into hospital, and maybe you could perhaps try and convey to people to have confidence in clinicians that everything is as safe as possible for patients to have rituximab.
Yeah, absolutely. So we have continued to go ahead with infusions and treatments that are necessary, but we have, in discussions certainly that I've had with a number of families, heard the concerns about coming into hospital, particularly early on. I think in April, May time, there were lots of concerns about that unknown, and certainly in terms of you know, the risks, that's understandable. You know, the hospital is somewhere where this infection is, and patients have this infection, and there has been within hospital transmission. But we're in a different position now compared to where we were early on in the pandemic, and those measures to reduce the risk of picking up the virus when you come to hospital are far less. And so all hospital workers as of the 15th of June are wearing masks on site, and I guess we have to, in the situation that we face, and a lot of the decisions that we've been talking about, we have to balance risks. And I think for this virus, it's going to be impossible to eliminate the risk of picking up the virus, but we want to reduce it to a safe level. And we balance the risk of picking up the virus with missing out on important treatments. So that's the stage. They're the discussions that are often really useful to have on an individual level with your individual teams, so that we can provide that reassurance that it is safe to come in and get the treatment and go through your concerns.
Thank you, Rachel. And Rachel, are you continuing with telephone consultations, or are you reverting back to face-to-face?
Yeah, so we're making an assessment based on the need. We've continued throughout with trying to maintain contact so that we don't lose touch. I think it's been important really to to have the opportunity to talk and reassure patients. So we've largely been able to do that by telephone, and we've got a new virtual platform as well that will enable us to go to the video virtual option. And then for families who do need to come and be assessed for a clinical, for children that need clinical assessment or blood tests, then clearly that's been face-to-face on our site, and that's continued actually through the pandemic. So in our outpatients department, actually, we were one of the few specialties that continued to see face-to-face. What's difficult is that we know we're not going to be able to go to full capacity. And so we're going to continue with a hybrid of face-to-face appointments for those patients who need them. So month by month, we do a triage and we figure out who needs to come for a face-to-face appointment. And then we otherwise make sure that we keep to the appointment schedule with either a virtual face-to-face or telephone appointment. Okay, thank you. Regarding obviously the research studies, obviously your laboratory started up again, and I know the team at Bristol, they've started doing their lab work. So obviously there's going to be lots of follow-up appointments for Nurture and Nephros, and I'm assuming they will resume at hospitals. Have they already resumed, or will do? Or I suppose it will be. We'll have to judge it by hospital. Yeah, we're certainly having those conversations, and on our site, we had a planning meeting just a couple of weeks ago to go through each of the studies that we're recruiting into in Manchester, to prioritise those ones that we needed to get up and going sooner rather than later. And so those, I'm sure lots of centres are having similar discussions, and that comes down to the local environment. Yeah. and logistics. And I guess the other factor is that a lot of the research nurses who are involved in recruiting to clinical trials in nephrology have diverted to helping with the clinical trial recruitment for trials for COVID-19. So there has been a bit of movement and redeployment of people to support that effort. But that is certainly in Manchester starting to come back to our normal teams, and we're looking at getting things going as soon as we safely can.
Okay, thank you. And I see, Sian, you've kindly replied to the question about the clinic environment that no time is spent waiting, no time spent in the waiting room, and pretty much a drive-through to have your blood test and clinical review. So I actually had to pop into the hospital myself for an appointment, and it was very much straight in, straight out, you know. So I think hospitals are doing a fantastic job, actually, of seeing people as quickly as possible, efficiently, and not bringing you in unless they really, really have to. So,
to Rachel's experience, we've kept going with face-to-face appointments where we've needed to right throughout. The biggest challenge has been the transplant recipients, because particularly in adult nephrology, these clinics tend to be very large. And we have actually used the large clinics for group sessions with our psychologist, with the dietitian, with our youth worker, who can see people when they're in the waiting room waiting for their clinic appointment. And we've had to stop all of that because of the importance of avoiding crowds and contact. So it is we were talking about this yesterday and saying the clinic is more or less drive-through and pharmacy is click and collect. So our pharmacists are taking requests for repeat prescriptions by email, and then they're just there for you to pick up when patients come. So it's completely different from earlier this year, and we can't continue like this because we are going to have other activities that we need to do that we're currently not doing. But at the same time, we can't go back to how we were at the beginning. So it is going to be a hybrid model of seeing patients in different ways at different times, and we're just working through that at the moment.
Yes, it's a very, very challenging time for you. Yes, and also probably training people for dialysis as well. That must be quite tricky. So,
yes, so there's been huge knock-on effects for patients coming up to needing dialysis, in that all our access surgery, so for making fistulas for hemodialysis and putting Tenkoffs in for PD, all our surgical activity stopped as well. So we're managing patients with lines now for dialysis, which is not ideal, and our planned living donor transplants have not gone ahead, which nationally is impacting now hundreds of people who were planned to have a transplant and are now either starting dialysis, which they were hoping to avoid, or continuing with dialysis longer than they hoped to. So the ripple effects from this for nephrology across the different aspects of it have been absolutely enormous, and I'm sure it's the case in other specialties as well.
It would it be possible, and I expect you've already discussed this with colleagues, to actually designate one hospital to do those transplantations?
Well, that's very interesting. So for living donor transplantation, I think at the beginning of the situation, when we didn't know how long this was going to be going on for, there was a sort of a little bit of and plus we were so busy dealing with patients who were unwell. But a number of options have been discussed, and one interesting thing that's happened is that the London Bridge Hospital, which is usually a private hospital but does have dialysis facilities, the transplant team from the Royal Free took it over last week, and they did 5 living donor transplants in a week. And it's planned, I think, next week that the team from Imperial will be using London Bridge Hospital to do a number of living donor transplants from their waiting list.
Yeah.
So that is happening in London, where geography and logistics make that sort of thing possible. We're talking about various measures locally, as even whether the donor operation could be done in our private hospital, and then the recipient operation would be in the hospital where we usually do this, because this is where we have dialysis in case the recipient needs it. So yes, logistically, people are now being very creative about how we manage this situation, because as Rachel has said, this virus isn't going away, and we're going to need to work around it. And in terms of safety, we're now doing a COVID test for everybody on our waiting list every 2 weeks. So we have, and that they then get tested again at the time of being called in before we would start any immunosuppression or actually do the transplant. So our whole surveillance has massively ramped up compared to where we were a couple of months ago.
So basically, the term "keep your eye on the ball" for everybody, it's like everybody's on your radar 24/7. It's not like looking at this week or next week all the time, isn't it? Yeah.
I think that's the situation for all of us in healthcare, and for patients in the system as well. So the advice on shielding changes, and so many factors are feeding into it. It's very rapidly changing.
I'd just like to add that for those of you who don't know, my son's got FSGS. He was diagnosed at the age of 5, and he's age 24 now, and he had many frequent plasma exchanges. Thankfully, he's not on it at the moment, and the kidney function is down, but he's stable, and he's able to work from home. And I'd just like to say that Southmead Hospital have been fantastic, like phoning him, sending him letters. His GP has been fantastic, giving him a direct line to talk to him about anything, even mental health issues. They've got his medicines sorted for him and sent to him. Fantastic. So I think on behalf of transplant patients, from what I'm hearing, they've been looked after extremely well. So thank you for that. Thank you very much. So thank you for sharing that information, Sian. Okay. Miriam, what time is it? Because I've not wisely put a clock in front of me.
It's 12:43 at the moment, Wendy.
12:43. Okay. So in the so I've got some remaining questions here in the inbox, and I'd quite like Ania in a little while to talk about LDL apheresis, what she's doing, and possibly Ben to talk about Prednos 3 a little bit. I know that's on hold at the moment if we get time, but if I can just ask some more questions which are in the box. I know some have already been answered.
Wendy, I still think that
I've got
some of the parents are still quite anxious about sending their children back into the outside world. And I think they do want to know about the level of what is a low level of tacrolimus, what is a high level, and how to kind of categorize their children as being high or low risk depending on the amount of immunosuppressant they're using.
Oh yes, there was a question earlier. Sorry, yes, there was a question about tacrolimus earlier.
And even if they've been off MMF, and if they've actually not had immunosuppression for a while, but they've been recovered, they're over it now a little bit. They're in remission. They're happy.
Yeah.
But their parents are still incredibly anxious about sending them into the outside world because they think that the child is actually doing well because they've been so shielded and protected for this period. So again, I think that anxiety is still very much real for parents. So I think if they could answer that as well, that'd be great. Thank you.
Yeah. Okay. Ania, could you answer that question about tacrolimus? I think you actually answered it in the inbox earlier. Are you still with us, Ania? Oh, you're on mute, Ania. Hello?
I don't think she's able to get off mute. If it would be nice if we could hear from Martin Christian as well.
Yeah, Martin, are you still there, Martin?
Yes, I'm still here, Wendy.
Could you kindly answer the question, the concerns about parents, about their children being immunosuppressed, about going to school?
So, I mean, we're following the BAPN guidance as well. What we have found, I think that's come out from other people, is a huge amount of anxiety because of the change in advice. And we had patients of children with transplants, and I'm sure this applies to parents with nephrotic syndrome, but we've got a WhatsApp group for many of our transplant patients, and parents who'd taken children out of school before the official advice came to close schools, when there was that sort of grey area, and so now many of these parents are feeling extremely anxious that they've been told it's safe for children to go back to school. And we tried to sort of steer a middle ground to say, well, okay, look, nobody's going to come in and send the educational welfare office around at the moment if you're not sending your children back to school. But actually the evidence is that the children are not at any more risk than other children. So these are for the mainly the nephrotic syndrome patients. Of course, like other people, and I've said earlier, the difficult thing is that this is a disease that relapses, and so it may be fine. We may be able to give one set of advice at the moment, but the moment that children relapse and they're taking high-dose steroids again, then we going by our advice, we would say, well, at this point you should be shielding again, and should be shielding again until the steroid level has come down to a reasonable level for a reasonable period of time. And I think we probably, perhaps defer to Yincent here, but I think we're a little bit grey in terms of how long children need to be at that lower dose of steroids before we say that they can stop shielding. So in terms of school, I mean, I would go by the BAPN advice and say, yes, that it should be okay to go back to school, but you need to satisfy yourself that school are putting those social distancing measures in place at the moment. 2 days at school, back at school, may not seem like very much, but actually probably an important number of days to go back to school, just to get your children back into seeing friends again, and then know that when it comes to the end of the summer holidays that it will be easier to go back to school. And it's something that we say when we tend to keep our newly transplanted children off school for a month anyway, and I think all of the different paediatric renal units have got slightly different policies about that, but I think broadly we follow the same sort of principle. There's a period of time after you've had a transplant when you're particularly immunosuppressed that we avoid children mixing too much. So if that quarantine period post-transplant, not in a COVID time now, finishes a week before the start of the holidays, I often say, well, yes, it's a good idea to go back to school now, because that'll make it so much easier for your child to go back to school again after the holidays. And I think this same principle applies now. It might just be a few days, but good.
It builds confidence. It builds confidence. Yincent, could I ask you to answer this question from Joe, please? Now, Joe's actually a primary school teacher. Thank you, Martin. Yincent still there?
Yes. Hello.
Hi. So if class sizes are back to 30 in September and it's not possible to social distance, is it still okay, bearing in mind the possibility of a second wave for this to happen? This is for my immunosuppressed child, and she's asking the question also because she's a primary school teacher herself. my concern is that after 5 months of shielding, any sort of bugs will be putting my child in a vulnerable position based on previous experiences. If you had any advice to give Joe,
yes.
please?
Well, I mean, I think we really just have to see how things go in the next 8 weeks, because the risk to children are not very great. However, it's good. You know, we want to avoid catching things, and that's why these measures such as, you know, washing hands, social distancing were put in. And we may find that we may hopefully find that during the summer break that there'll be a big push for the schools to be able to keep children safe and keep the teachers safe as well. And I suspect most schools will be doing something a bit novel to minimize too much mixing as well. So I think we just have to watch this space. The generic shielding advice. So there's our shielding advice, you know, about what levels of immunosuppression, but there's also the shielding guidance from the government as well, which may also change. So it's already changed once already, where families, you know, people who are shielding are able to go and exercise, and we really encourage, you know, the small number of children who are really shielding to actually take that up. Because I think when it first started, we were very worried about children, you know, especially many of our patients live in small flats who've got no outside space, being really surrounded by the four walls. And so I think we do have to be sensible and help our children not to be too isolated as well.
Okay, thank you, Yincent. Thank you. I have another.
Add something quickly about that. Sorry.
It's good, Karen. Yes.
Because it comes up all the time with nephrotic syndrome, not just COVID. We know that viral infections especially trigger off relapses in nephrotic syndrome. And any parent on the call of a child with nephrotic syndrome who goes to nursery, who goes to reception, and suddenly gets all those bugs, relapses are almost inevitable. So it's not just during COVID times, it's any viral infections. So going back to school in September, even if it wasn't COVID time, you are naturally going to get all the winter viruses coming out and all the relapses. So it's always going to be balancing, but you can't completely shield away from all infections. And actually children, there's good advice, good evidence children need to get infections as children, because that's what builds up your immune system as you go into adulthood, etc. So you're never going to avoid all infections. And I think it's one that all nephrotic syndrome parents are well aware of, that infections cause relapses, and we always have that balance when especially the younger children are going to school, going to nursery, etc., and not being able to avoid all those infections.
Okay, thank you. I have a question here from Andrew Clark. My son, aged 13, has for the first time in 11 years come off all his mess. I think you're probably referring to all the medication. 8 weeks free from MMF. Can you please advise what is the best way to introduce the outside world? I don't know if you can answer that question, somebody for me, please. Perhaps Hazel or Ania?
I think I think it's quite difficult. I mean, your immune system takes about 3 months to 6 months to recover after prolonged immunosuppression. I mean, as long as social distancing is maintained, and I'm very well aware that actually one has to protect the vulnerable individual, because people have completely, certainly around us and what I can see, have very much stopped social distancing. So I think as long as you're not close to anybody and you wash your hands and follow all the guidelines, then you've got to get people out. Because actually, having had to drag my youngest to school after 3 months of shielding because she was so anxious about meeting anyone else, I think you've got to get the kids out, particularly if they're teenagers, because suddenly I think the mental health issues of all this at the moment are understudied and under thought about, because we're all concerned about what happens if the COVID-19 hits my child, hits my relative, hits my husband. But actually the mental health issues are quite significant as well. And I think there certainly one of our doctors has been looking at another type of patient group we've had to shield as well, and there's a lot of anxiety disorders, a lot of quite significant mental health issues coming out. So I think it's always just this balancing act of what do you do. However, you know, theoretically, after stopping immunosuppression, 3 months is when you can start to vaccinate. 6 months is safer. So 11 weeks is almost 3 months. And as long as you follow the social distancing guidelines, you should be okay. I certainly have been finding areas around London that you can go to and walk a dog and a vulnerable husband without meeting anyone. So it's always possible.
Okay, thank you,
On
Ania.
this, Wendy? Can I do a comment?
Kjell. Yes, absolutely.
There was actually a paper coming out this week from Bristol, who was a child psychiatrist that looked and described a lot of problems for the children who had been treated, which is what we have worried about. And you can find that. It's out there since 2-3 days.
Yes. That's one thing I'm very concerned about. I now and again I have little chats with especially our young adults, and some of them sadly have presented with the post-traumatic stress from all their treatments, you know, long term. So yeah, I'll be interested to read that. Thank you for sharing that. Thank you. Some other very important questions to ask. I'm sort of conscious of time, but one from and I apologise, I don't know how to pronounce your name, Afzal. How long would it take for a person with a low immune system to develop antibodies to fight COVID-19? Do you know the answer to this, Kjell, at all?
There is a chance, if you're immunosuppressed, that you don't develop antibodies. We don't know that. That needs to be studied.
Yeah, okay.
Yeah, there's a possibility that you don't develop antibodies, and in the same way that some patients with nephrotic syndrome lose their immunity to various things like measles and chickenpox that they had previously through the loss of all the antibodies through the urine. If you get very, very badly controlled nephrotic syndrome, there's always a little bit of a risk of it. You know, it's one of the things that we thought about when we were designing our shielding, looking at people who are shielding, and if you're immunosuppressed, are you ever going to be raising an IgG? Is the result going to be valid anyway? Because you just don't know, is it going to be below the limit of detection by the assay? That's the other thing. But there's always a risk if you're immunosuppressed, but you just don't raise resistance to an infection. That's a lot of the problem.
It's a hope, however, that the other part, the other branch of the immune system might be more important than antibodies, that the T cell memory and the T cell response. So we shouldn't just give up on the antibodies, and it's so much more difficult to study the T cell response than just looking for antibodies. So they could respond even if we can't measure it. And it's a lot of studying to do that, to know exactly what is true.
Yeah, I would just follow that comment from Kjell. I think one I guess note of optimism in terms of the research. Actually, this whole situation has shown us what is possible at pace. And so we're learning a huge amount about this infection, and that's really going to continue to improve the advice that we're going to be able to give. And all of the questions, the really, really important and interesting questions about antibody levels and T cell responses, I think, you know, will come through the research that is going alongside many of the big studies in adults and in children, looking at antibody levels, but also looking at when vaccines come through, looking at how different groups of individuals are responding. So I guess the kind of positive note is that there's a huge effort that's going into trying to understand all of this, and I'm sure that will improve the situation for us.
Thank you, Rachel. I suppose we've all got to be patient. Everybody's still learning, aren't they? So, and there's a question about a vaccine from a mum. When it becomes available, how high up on the list would our children be to get it? She's saying that her daughter's on a low dose of prednisolone and levamisole.
I think personally, speaking for the patients in my clinic, if it is a inactivated vaccine as opposed to a live vaccine, which can't be given to immunosuppressed patients, I'll probably be busy trying to vaccinate everyone just for a safety thing. And also, it then, once you've got a vaccine, you've got herd immunity for everybody, then a lot of the issues about do I socially distance, do I go to school or not, come away. The only problem is we don't know when this is going to occur. And whether you need more than one dose of vaccine. That's the other problem.
Thank you.
If you look at this from a society point of view, we all will want to vaccinate everybody, but I'm sure that we will need to decide to vaccinate those who we know are faring worst. And that will be people who look like me and worse. That's the risk group. And then I'm sure you will give priority to hospital staff to make it easier to give good care in safe ways. And I would assume that actually all children will come very low on the list. Thank
you. And Sian's made a very important point that a vaccine response is likely to be different in adults with advanced kidney disease or a transplant. So that is important to remember as well.
Yeah, we know that the Oxford vaccine trials are underway across the country, and also the West London, the Imperial vaccine in London. The British Transplantation Society has fed back to the Oxford group that transplant recipients are a particularly vulnerable group and are likely to have a different response to the vaccine compared to the general population who do not have a transplant. So we have asked if they could be considered as one of the priority groups when other groups are being considered. I think the other aspect of the vaccine trials is that we can look at laboratory tests for the antibody response and other aspects of the immune response, but the real kind of proof of the vaccine is it preventing infection. So I do think it's interesting that the trials are currently being run in South America, so in Brazil, where there's a current high incidence of acute infection, so that in addition to the laboratory tests, we can also demonstrate quickly that it's being clinically effective in preventing infection.
Thank you. Thank you very much. I have a question here from Christine. Should renal patients take up the bubble allowed by the government? Martin, are you able to answer that question for us, please?
I'm not sure whether Christine's speaking as a parent of a child with kidney disease or as a kidney patient herself, and I think that probably the advice is different as to whether we're talking about adults or children. I think if it's children, I think, again, in line with the BAPN advice.
Actually, it's an adult. It's an adult.
Yeah.
Yeah.
Okay.
Yes, members.
So it might be better to defer it to Sian, perhaps.
Yes. Sian, would you be able to answer that question?
I think the whole bubble idea has been to emphasise the fact that your risk of infection depends on the number of people you see, how close you are to them, and how long you spend with them. So I think the bubble is quite a nice way of visualising the idea that you have been shielding and you're only going to go and see one other person who themselves has had limited contact with other people. So you're reducing the chance of you being exposed to infection. And I think that's the aspect of the bubbling to remember. So it's a question of weighing the chance of anybody having been exposed to the virus, and then you minimising your chance by distancing, washing your hands, and those measures. Does that make sense?
Yes. Thank you very much. Thank you.
Hi, Wendy. Just to let you know that we've just passed the 1 o'clock mark.
Yeah, I was conscious of that. We
have to lose some members of the panel that actually do have.
Yes, everybody's going off to other meetings. I don't think it's fair to keep everybody still. Everybody's very, very, very busy. I think most of the questions have been answered. If clinicians have got free time to answer any that haven't been answered, please do so. I'll be very, very grateful indeed. If there's still questions to be asked, please Facebook me, message them to me, and I'll try and get someone to answer the question if I can't answer it for you, everybody. But thank you so much to everybody on the panel. Thank you for your time. It's been fantastic. And thank you for all your hard work on the wards. And I know you're still working very, very hard to keep on top of everything for everybody and keep people safe. And, you know, we admire your courage and dedication to your work. And perhaps in another, if we have another virtual call, maybe I could get some of you to share your research with us as well, please. And everybody is saying how invaluable it's been, and thank you very much for such a useful call. Everybody's saying thank you very much. If you see little comments in the box, it's been fantastic. And thank you, Maryam, for supporting me. That's been fantastic.
Pleasure. Thank you for the panel.
Thank you very much indeed.
Thank you.
Keep safe, everybody.
Thank you, guys.
Bye-bye. Bye.